Our next session shifts our focus from optimization to preparation before the patient even enters the operating room. Prehabilitation is increasingly becoming a key part of improving surgical outcomes, and understanding the what and the why from a surgeon's perspective is especially valuable. To take us through this, we have Dr. Aparna MJ, Associate Professor from the Department of HPB Surgery, CMC Vellore. Jacob Philip, Professor and Head of Department of Uro-Oncology, CMC Vellore, and Dr. Satish Kumar, Professor, Department of Anaesthesia, CMC Vellore, who will be moderating this session. May I request you all to kindly take the stage?
Good morning, everyone. The question I was supposed to answer was prehabilitation, what and why. I know the challenge that it is to talk after Nitish, but I will still try. I will start off with a question back at you. As an anesthetist, what do you think is the right time to see the patient preoperatively? I will see if we get anywhere close to answering this question at the end of my talk, and we'll see if we can come back to this. So out of the two questions, the why part of it is the easier one to answer. I'll start off with that. We have studies dating back to 2020, a systematic review which clearly showed significant reduction in complication rate when patients were prehabilitated adequately for complex HPB surgeries. And then we have something as recent as 6 months ago, another retrospective cohort study. So there have been lots of studies spanning through the last 6 years where we've clearly seen a reduction in complication rate when patients have been prehabilitated. There's one thing though in all of these studies is we've not seen any difference in the mean hospital stay. I'll see if we can come back to that as well at the end of my talk, whether we should even be looking at it at all. Now, this is from one of the publications in 2018 in Anaesthesia, which actually tries to show how all patients actually dip to a level of dependency at the time of surgery, irrespective of their baseline status. The graph line A is a situation where even if not prehabilitated, they do well if they do not have any complications. Whereas the line B is one where they do have complications and haven't been prehabilitated appropriately, then they continue to remain below the level of dependency. The line C is the most optimum one, where if they have been prehabilitated and they do end up with complications, they still get above the line of dependency. And D is if prehabilitated and they do have complications, they take time, but still they manage to get above that line. So that is the effect of prehabilitation, particularly in the context if they do have complications. Now, as a HPB surgeon, the two most complex operations for us, barring transplant, will be major hepatectomy and Whipple pancreatic duodenectomy. So on the left is a list of indications for which we do major hepatectomies. The first box is a list of indications where patients generally do not have jaundice, and hence they are relatively well preserved apart from the common factors of cancer, cachexia and all of that. The absence of jaundice itself makes them relatively well preserved. Whereas the next two diagnoses is one where we have to deal with the challenge of jaundice. The diagnoses on the right side are those situations where they present with jaundice and need to have a Whipple pancreatic duodenectomy. And then when there is duodenal carcinoma, there's an extra challenge of gastric outlet obstruction as well, which adds to our challenge in terms of prehabilitating these patients. Now what? That's the next question. So the surgery of the Society of Oncology defined it as an intervention administered before an operation designed to prepare the patient for cardiovascular, pulmonary and metabolic demands of undergoing a major abdominal surgery and to minimize impairment from underlying comorbidities. In essence, it aims to optimize a patient's health and fitness to facilitate faster post-operative recovery. But the current model is actually a tri-modal prehabilitation technique which involves physical fitness, nutrition and emotional readiness. But what are the roadblocks in each of these? Just like Nitish was just mentioning, the sarcopenia and easy fatigability in all of these patients, which is going to come in the way of focusing on their physical fitness. This cancer, cachexia and micronutrient deficiency, that's again a challenge for their nutrition. And the emotional readiness. They are in extreme emotional vulnerability, they go through fear and anxiety, and it's also part of our job to take care of that factor as well. Now, why are they frail? So apart from actually being able to design a prehabilitation model which applies in general, as a HPB surgeon, like I mentioned, there are some extra challenges that we face because of the kind of presentation that these patients have. And I would just quickly focus on these, and then I would go on to what our model for prehabilitation is. So jaundice and sepsis, jaundice by itself has a lot of problems. It causes hemodynamic effects, coagulation problems, disturbances in wound healing. And like you would know, in patients requiring major hepatectomy, it is a major deterrent to post-operative liver regeneration and ends up causing liver failure. So this is how jaundice will actually come in the way of liver regeneration. What I would like to push across here is you would, as an anesthetist, have seen situations where Whipple pancreatic duodenectomy is done with a jaundice of 15, 20, 25 maybe, but we would never do a major liver resection without the bilirubin coming down to below 3. So in a Whipple pancreatic duodenectomy, the only situation where we prefer biliary drainage if there's been cholangitis, which is a separate indication. The other thing is malnutrition. So how do we assess malnutrition? That has been the biggest challenge for us. So we do fixed targets, like if the malnutrition persists beyond a certain period of trying to rehabilitate them nutritionally, we will try to stent. But what is objectivity to malnutrition? Just like Nitish mentioned, we have always been counting on albumin levels. However skewed it may be for various other reasons, we have not had a more formidable measure of nutritional status, at least as a biochemical marker for us. And there have been studies which have shown pre-albumin is maybe slightly better, but the only difference is that the half-life is slightly shorter. Albumin has a half-life of about 7 days. Pre-albumin has got a half-life of about 2 to 3 days. So it just reflects a little bit more quickly of what is happening. But what is important is both of these are negative acute phase reactants, and the moment there's a small infection or an inflammation, both of them tend to drop. And then you do not know whether that's just the nutritional status or the sepsis. And then there are problems like renal losses related to diabetes, or just malignancy itself causes a lot of GI loss of proteins, all of which is not possible to account for. However, we have not found a more formidable objective marker, and we still do count on albumin. And a liver resection would definitely be a no when the albumin is below 3, but when we have to do a Whipple between 3 to 3.5, we still do it with a lot of reservations. Our cutoff still remains 3.5 for a Whipple. So just to show an example, this is a patient who had cholangitis and then at presentation had ascites when the albumin was 2.6 and was generally considered unfit for an operation because of the amount of ascites that was there, which is on the picture on the left. But then we worked on his prehabilitation, brought up his albumin to 3.9. The ascites completely disappeared. The sarcopenia is still there, but he is able to go through our prehabilitation requirements, and then we're planning to operate him very soon. So what if we do operate with a low albumin? What are the challenges that we face? So there is going to be a lot of bowel anastomosis in Whipple, and even in a hepatectomy, if there's going to be a hepaticojejunostomy, the anastomosis is going to be extremely at risk if we are going to be operating with low albumin levels. We are putting the patient through a very high risk of leak, and then there's risk of wound dehiscence, ascites, and the predilection for infection as well. The next problem is gastric outlet obstruction. This is particularly in the case of duodenal carcinoma, large volume losses, dyselectrolytemia, and if we manage to get in a nasojejunal tube, at least it gives us a way to feed. Otherwise, we're counting on TPN. In the background of jaundice, then to balance out TPN is going to be an extra challenge. And the other problem is that these patients have some amount of malignant gastroparesis, which means post-operatively as well, they are not going to return back to normal eating very quickly. So we need to factor this in as well when we plan for their nutrition in the pre-op. Liver disease and portal hypertension, again, it's going to be done only in child A patients, but again, we're going to be operating with probably borderline albumin, and maybe there's a little bit of renal dysfunction. We have to be prepared for the amount of blood loss that we will face, and again, the risk of infection. There's a group of patients that we currently see post-hepatocellular carcinoma receiving immunotherapy, and the colorectal cancers which come to us after chemotherapy. So this again, there's going to be a cooling off period of at least 6 weeks where we have some time to build them up, just like what Ranjan sir was just mentioning. And then, however, there's been terrible bone marrow suppression at this time. And for immunotherapy, we do not even know still what all are the effects that we are going to deal with when we do a liver resection. So that's another challenge. And then again, while using platinum components and irinotecan, the risk of blood loss and the risk for post-operative infection. There's a little bit of fat-soluble vitamin deficiency in jaundice patients, the vitamin A, D, E, K. And because of chronic pancreatic duct obstruction in these patients, there's going to be pancreatic enzyme deficiency as well. So these are all the things that we try to take care in addition to a normal model of prehabilitation that we have come up with. So the highlights of our prehabilitation model, we have been doing it reasonably systematically since maybe 2022, and the prehabilitation for our patients starts the day the diagnosis is made. There are 2 nurses who specialize in prehabilitation in HPB. We have a dedicated space in our outpatient department with 2 treadmills lodged there as well. And the focus is on nutrition, physical fitness, micronutrient supplement, tribal incentives, spirometry, and each patient is assessed at least 3 times over the period of 2 weeks before they're actually considered fit for the operation. So this is the space in our OPD. And I am just going to draw your attention to the form on the right. This is the record that our nurses use, bringing your focus to this part where they go through the nutrition and the physical fitness. So when it comes to nutrition, the problems of malnutrition, particularly in cancer, can be without inflammation, and then there are other factors like socioeconomic status and all that. But the part that is most challenging for us is the one which is associated with inflammation. This inflammation is either because of an infection or just because of the cancer cachexia itself. So we need to start off with some sort of a scale to assess what the baseline nutritional status is. So the one we actually use now is the subjective global assessment, which is very comprehensive, but like the name would mention, it is very subjective. So if you would like some objectivity for that, there is the nutritional risk score from 2002, which is an online model. And if your answer to the first 4 questions is no, then you don't have to go through the rest of it. The patient is actually considered low risk for malnutrition. But if you do have any of the yes, then you go through the rest of it, which takes into consideration in terms of the amount of food intake over the past 2 weeks and in terms of what the disease condition is and the patient's age. And it comes up with a score. 5 and above are considered high risk, and it actually has some kind of suggestion about what could be done as well. So what do we try to do at the end of all this? This is a table which actually shows what a normal standard diet looks like versus what a hospital diet or a diet aimed at nutritionally prehabilitating someone should look like. So we're looking at least 30 kilocalorie per kg body weight per day, and a protein intake at least of 1.2 to 2 gram. And it has to be without extra sugar, and all the micronutrients and all that also have to be present. And the fasting state is preferably not more than 10 hours, and there is a very low threshold to add oral nutritional supplements, and if nothing of this is working, then a low threshold to go into other forms of enteral feeding like tube feeding in the form of a nasogastric or nasojejunal tube as well. So this is what our nurses use. This is actually a table which shows on the left is what the standard food items are in terms of its composition, and based on our patients and what they've been telling us about what they consume, we've also tried to find out what the composition of many of these other food items are. And there is also a chart to guide us depending upon the various physiological states, their work nature, which tells us what is the kind of calorie and protein they need to take. Based on this, a diet chart is actually drawn up the first time they visit our OPD, the time the diagnosis is made and the plan for operation is made. And on the top is the requirement, and based on a 24-hour recall, during their next visit, it is seen whether their required calorie and protein intake was achieved or it was not achieved. So if there is a problem in achieving it with a normal just a diet which is drawn out for them without supplements, there's a low threshold to add on oral nutritional supplements. So there are about 20 products in the market, but the ones most commonly used by us are the Cabipro and the Ren-HP. The Cabipro has got about 43 kilocalorie and 5 gram protein per scoop, and each scoop is about 12 gram portion of the powder. So in addition to what is actually being given in the form of diet, we also do add on to this. This is the ESPEN guidelines, which clearly tells us that when the nutritional risk score is less than 4, you could possibly quickly take them through an operation, and the possibility that they will go through ERAs after the operation as well is much higher. But when the risk score is more than 5, then we need to spend at least about 10 to 12 days prehabilitating them. Maybe focus on just giving it with diet itself to begin with, and if the intake is at least not 50 to 75% of what the target is, then quickly add on oral nutritional supplements. Now this is the other focus that we've been working on. So everybody goes through the incentive spirometer, and we've used it as an important screening test. And even if they start off only with the 900 cc to begin with, unless they actually use 1200 cc on this, we have not been comfortable clearing them for an operation. So that's the OPD space, where we also have a whiteboard where our nurses will actually document every time a patient has become fit. So even if we don't have an opportunity to interact with them, we walk in at a different time in the day, we just go there and see if a patient has been cleared or not cleared, and then if they haven't, we know the progress by talking to them. We have 2 treadmills, and on that we have actually been doing the 6-minute walk test. So this is an online calculator which gives us, based on the gender, age, height and weight, and the 85%, which is the lowest limit allowable on the 6-minute walk test, is what we have allowed. And when they do not reach at least this, then we're not happy to actually take up a major operation on our patients. So this is another randomized trial which actually showed that incremental walking distances, so over a period of time, if they are able to achieve more, so even if they are only able to achieve 70% of the distance to start off with, what we focus on is incremental progress over the next visits, which has brought us to this point where we said at least 3 visits, and we make sure they actually show progress over the period of the 3 visits. And we also note down if there were any difficulties in terms of desaturation, tachypnea, what caused them to not complete this test. So how has it helped us? For us, it has served as a major screening tool. It has helped us to understand if this patient needs to go through any extra cardiac evaluation like a TMT or an angio, need for formal spirometry or a CPET. It has also become more goal-driven for our patients. There's objectivity. Now, a patient understands what we are trying to tell them when they say they are fit or not fit. So they also see the point, and there's more objectivity. Inside the team, everyone's understanding of fitness has also become uniform. I'm not going to say someone's fit and another person is going to say this patient is not fit. So there's a lot more objectivity within the team as well. It also helps us prepare for a rocky post-op. If we do decide to take somebody who has not reached our expectations, we know what we are going to deal with in the post-op period. More importantly, our nurses have experienced phenomenal gratification, and that's actually making them a big part of the team, and we also are very happy when they are happy. We have just started looking back at our data. I do not have any numbers to show you now. Our anesthetist can probably back it up if I'm wrong. Almost 99% of the patients are extubated on table for us. Even if somebody is shifted on a ventilator to the ICU, they're at best extubated the next day. We have close to 0 incidents of postoperative pneumonia. All patients, including major hepatectomies, are up and about the next morning. By morning, they are at least making like 4-5 rounds in our HDU. And if there were to be a complication after all of this, there's definitely a lot more reserve to tackle with this complication. Brings back to this question of should we be considering hospital stay as an important yardstick at all? So in a setup like ours particularly, an extra 2 days in the ward, in the hospital, is really not going to make the difference. What is really going to make the difference is the amount of time spent on a ventilator, going back to ICU if there is a complication, costly antibiotics, TPN. These are the things which push up the cost. So should we be worried about the mean hospital stay not coming down in all of these studies? Probably not. That's probably not the goalpost we should be aiming for at all. So this is very clearly shown in this RCT, which was just published a week back in JAMA, which actually talks about prehabilitation in major hepatectomies, where the single objective that they've looked at is only the Clavin-Dindo complication rate, and have completely done away with looking at the hospital stay. That's probably what we should be aiming for, and we shouldn't be focusing too much on bringing down the hospital stay. That brings me back to the last slide, and again, the question that I asked first, what is the ideal time to see the patient preoperatively for an anesthetist? I don't know if I helped answer that question, but I will just tell you what has helped for us. We generally talk to the anesthetist, our team of anesthetists, very early when we know we're dealing with a high-risk patient. Their input in terms of what is adequate cardiopulmonary optimization is very, very crucial for us. So they have already seen the patient once before patient is actually sent to the pre-anesthetic clinic, and we take their input and then we do further evaluation based on that. And when they come back for the case, they also know what the patient has been through. They are better prepared for what the challenges are going to be in terms of equipment, whatever they need to arrange, and all of that, they completely take care. And that's definitely made life so much easier for us, and it's improved the patient outcome for us as well. That's our two fantastic nurses and our team. Thank you very much.
Excellent talk.
Thanks.
And well positioned just after Nitish's sarcopenia talk. And I think this initiative, which is having a treadmill in your OPD itself, should be new. That's probably the first that I've heard of a clinical unit having the treadmill there, and that needs applause. And are you happy to take patients across the OPD?
Oh, absolutely, no problem.
So we do practice the nutritional part of it, which is the prehab. We do give protein powder because it's quite a lot of effort to tell them to eat all that, so just take the powder and give it. But we haven't done this physical one, so I think that goes a long way. Question, I think what Ranjan had alluded to, the 6 weeks or the 12 weeks that you wait, is there a possibility you ever find that after that they actually become inoperable? Is there a small number which stages, up stages?
So for us, the number of situations where we do after neoadjuvant therapy itself is very little, sir. So most of our malignancies are resected upfront. But the challenge we face is while we are preparing for this, yes, we do. But we've also come to the understanding that it's not going to be a win either way. If we take them to an operation when they're not adequately optimized, they probably are not going to come out of the operation well, and if it's progressing that fast, again, we tend to believe that the biology is also that aggressive. So it's not possible to rush in a poorly optimized patient just because the cancer is going to progress that quickly. It's only in the neoadjuvant situation where we push for 6 weeks. But the conventional prehab, we've now just kept it at 2 weeks, and third week, we would like the patient to reach operation table if everything goes as per plan.
Thanks, Aparna.
Thank you.
It's a wonderful rehabilitation program. Suppose if the patient cannot take orally properly, do you push with parenteral albumin and parenteral iron to get to your values? What is the difference if this enteral and parenteral supplements?
So albumin we've again not done too much, sir, because we do not know what's actually causing the albumin to be low. So IV albumin, just as a number, to get that number up by giving IV albumin for 3 days, we don't think reflects really in terms of all the advantages we have. We would still like to put in an NJ tube if that's feasible, and then at least a nasogastric if it's just the cachexia which is stopping them from not eating properly. Even if there's not really a mechanical obstruction, sometimes what has helped is just a small lumen tube, and the same nutritional supplement we've been giving through a 10 French tube or something diluted if they're not able to take orally. Our threshold for TPN is actually very, very high. Cost, of course, is one of the factors, and in the jaundice context, we need to then go for the lipid-free TPN and all of that, which keeps adding to the cost in the preoperative period itself. So definitely very, very high threshold. Our preference is always enteral, and definitely not much of IV albumin at all. Iron we have recently started. We have given 1 dose, and then if needed, if they are still waiting on the prehab program to get better, 3 weeks apart a second dose. But that's just started very recently.
Which type of iron?
Injection iron,
that
maltose.
carboxymaltose.
Yes, that is what we are using. So we've just started that.
Thank you. Any questions from the audience?
One thing is that you mentioned about this 6-minute walk test and you are doing on a treadmill. So that 6-minute walk test on a treadmill and on a floor are not interchangeable. You cannot really tell the patient to do the 6-minute walk on treadmill. On treadmill is a different thing. They hold both the handles and then the walk deck, because it's not their natural pace and the natural balance they have on the treadmill. So like whatever cutoff we have for the 6-minute walk test, like my patient need to walk for 350 meters to give fitness, will not really change cannot be interchanged on the treadmill test. Second thing is that you also mentioned about the length of stay in the hospital for the visit. That should not be an outcome. That's okay. But one more thing that patient need to, how early they are going for their oncological treatment after the surgery.
Correct.
For the RIOT, the return to internal oncology treatment, that is an important parameter when we look for the recovery path, because they need to get their adjuvant chemotherapy as soon as possible. And for that thing, I think the hospital stay may be one of the factor if they have but that will ultimately depend on the complications. So if the patient have more complications, they're more going to stay in the hospital and their arrival will be delayed. So that's it.
Yes, agreed, sir. The treadmill, we do it because it's easier, it is limited in one space, otherwise they're going to be walking up and down in the OPD. But when they do have difficulty for various reasons, they can't get that coordination and all that, we have some space and then we wait for the OPD to get over, and those few patients, we still try to make them walk in our OPD space. We do not just reject anybody because they couldn't just coordinate on the treadmill. So we would still put them on the flat surface walking, just that otherwise it would be parading down in the OPD and it's not very organized. That's why we've kept at the treadmill, and it's not on any inclination, it's a flat thing on the treadmill. Yet patients could have difficulty coordinating, but we do then check it on the flat surface, particularly with elderly people having bad osteoarthritis and all that. They're very uncomfortable getting onto a treadmill. For them, we do it on a flat surface.
So what cutoff you take on the treadmill?
The distance is what we calculate based on the calculator, and 85% of their expected distance is what we expect. And if they start off with a 70, then we expect them to get to that 85. We're also focusing on the progressive improvement.
But the 6-minute walk distance values that you are using, are they validated for walking on the treadmill?
May not be.
Yeah, because they are
But this is not an objective measure. I am not going to report a 6-minute walk test as a thing. This is a rehabilitation screening tool for me. So I'm not going to be giving them a 6-minute walk test report for it to be validated. This is just a screening tool to see if the patient that I'm seeing is fit for an operation or not. We chose to call it the 6-minute walk test because we do it for 6 minutes. It can just be called a walk test.
Yeah, you're looking at the improvement for
Yes.
individual patients.
Yes, yes, yes.
Most of the hospitals doesn't have the space, like, to
Correct.
find a corridor. So you,
Yes.
yeah.
Yeah, you just need a corridor,
So
yeah.
what I'm suggesting is it's a good initiative. You can make a standard and reference, and you can publish it so that the other hospitals can also use it.
That's what I would say, because if you go to our OPD, it will be very crowded. Even walking, you need a traffic signal. Okay, so you cannot walk 6 minutes in that. So this is a good initiative. I think they should take it forward and say other people also can
So,
forward. Then it will become a
can be
guideline
implemented
later on.
across all
Only
hospitals.
thing is that the patient should not hold the grills and all, because it takes a different way. They will change the result dramatically.
No, the standards will be different
Maybe
for
the
that.
standard may be different, more distance probably.
Yes.
Yeah.
No, but they're holding the first time, they're holding the next time, and they're holding the third time. So if you're seeing the improvement,
Progress, yes.
I mean, I would say that
And
for the circumstances and the way you have put it, it is good. I mean, now not having, because there's so many people, we cannot work, this is wonderful. I should say, they are actually absolutely right for that shift, but you can make your own standard.
Okay.
I think the point was it's easier to walk on a treadmill than outside. So if 6 minute is the walk test used, maybe you have to make it 8 or 9.
Yeah, possibly.
No, the only thing is it cannot be used as a cutoff to decide whether the patient the patient's fitness for surgery. Normally, you would use it as a surrogate for CPET. You couldn't do it if you're doing the same on a treadmill. But for individual patients,
Yes.
just to ensure
See
and
incremental
check
response and
whether
yes.
their prehabilitation
Exactly, yeah.
response is good,
Yes.
you can definitely use it. That's
But I think if you take it to the next step,
We can compare. We can compare.
standardization, tell them not to hold, not to do this, that.
Yeah,
Standard and validate.
possibly, yes.
For giving us anesthesiologists a different outlook and understanding on surgical prehabilitation. It's heartwarming to know that surgical fitness is something we see eye to eye on. Also, would like to thank Dr. Arun and Dr. Satish for moderating the session and adding your valuable inputs. Could I please request the both of you to hand over the memento to Dr. Parnam?